Ladies and gentlemen, dear friends, welcome to yet another virtual meeting of Thalassemia International Federation. And this will be the second part of our webinar program referred to Access to Innovative Therapies, Part 2. Part 1 was on gene therapy, as you remember, a few weeks ago. And this is Part 2 with the second innovative therapy referred to luspatercept, or the registered name Reblozyl. So allow me first to thank the international experts that are participating in this discussion. Please mute yourself so that we can facilitate the discussion. So allow me to thank Professor Cabellini, Professor John Porter, Professor V.Viprakasit, and Professor Aydinok shortly joining us for the discussion. So it is a privilege for me, as always, to represent the Thalassemia International Federation, an umbrella federation that started back in 1986 with a few founding members, patients and parents, and a few medical advisors, today embracing and safeguarding the rights of patients in more than 200 national thalassemia associations across the 6 regions of the world as defined by World Health Organization, and with a wide network of collaborators. The work of TIF focus, of course, on the rights of the patients and the needs, the unmet needs of the patients, focuses on 5 pillars of activities, amongst which educational program, networking, and undertaking of relevant projects constitute 3 of the major pillars of our work. How does TIF ensure that the patient voice is heard and the patient voice heard at the decision-making level? Well, through the years, we have had the National Thalassemia Association workshops, we have had the meetings, the conferences, but in current years, we have developed other programs, including, of course, the development of the patient advocacy group and the access programs, which is specifically focused on improving and supporting access of innovative therapies and interactive discussion at the decision-making level. Of course, the slide shows some of the important activities of Thalassemia International Federation, for which we are very thankful and grateful to our international expert group. The guidelines are currently the last 4th edition, 2021, just published. The Global Thalassemia Review 2021, which compiles all the available data on the patient's perspective of their health services and their quality of life, and a number of other activities that I'm sure you're all aware of. Yeah. How does TIF reach the decision makers? Well, we would like to reach at the level of the decision to achieve the active contribution of the patient's voice and position. And 2 of the most important components of these action or activity of TIF include the educational and capacity building for becoming what was originally called an expert patient, now referred to as an advocate, patient advocate, and the development of the TIF patient advocacy group at the global, regional, and national level. Now, what is an expert patient? Well, it's a very vague and very difficult and complex definition, but what TIF believes is an expert patient is a patient who is empowered with the skills, confidence, and knowledge to play an active role, a meaningful role in making informed decisions and in having a meaningful discussion and interaction at the decision level, at the decision-making level. Today, of course, an expert patient is called a patient advocate, And TIF has proceeded on a very important and complex project to educate patients across the world in the different countries, so that we have at the national, regional, and international level patients who belong to National Thalassemia Association, who understand and know the needs of the patients, both in their country but also in their region and globally, who have completed educational courses and educational programs that TIF provides for them, and who have quite adequate knowledge of their own healthcare system, public and social care services in their country, so that they can identify unmet needs and they can advocate for addressing their needs. We have prescribed a number of roles for our patient advocate group across the globe, such as advocating for TIF's mission, maintaining an up-to-date understanding of the needs of the patients in their country and globally, representing TIF in missions, and provide their opinion and perspective as patients when and if required, either in a group of academia, industry, or at the level of the governments. But of course, TIF bears responsibilities towards these patient advocate members to sustain an interaction with the TIF International Advisory Committee, to ensure that they undertake successfully the educational programs and, most importantly, the THALI course, and to develop targeted and specific preparatory or training materials for them to address their advocacy needs appropriately, and of course cover the costs of their work. This is how our patient advocacy group looks like. So we have patients at the country level, at the regional level, and international, who support the work of TIF in the context of advocacy. A very important project has been undertaken by TIF also in the last 10 years, referred to as the Access Program, which is TIF's International Forum on Accessibility, Effectiveness, and Sustainability of Therapies for Hemoglobin Disorders. We are focused on supporting the promotion towards availability and accessibility of our patients to advanced therapies. And we are focusing on ensuring equal access of these innovative treatments to all patients across the world by bridging the knowledge communication gap that, for sure, I'm confident you are aware of, exists among interested stakeholders. Who are the interested stakeholders? The patients, of course, above all, the healthcare professionals, the general public, the policymakers, regulatory competent authorities, and of course the academia and research community. And this is how the project works. And this webinar today is part of our TIF Access program to discuss with international experts and patients on how we can advance access to innovative therapies, what are their concerns, and what are their challenges. We're not going to cover, of course, Reblozyl, because this is the role of the international experts who are interacting in this webinar. TIF is very grateful to each one of them. Reblozyl is, as we know, from the patient's perspective, an agent that matures the red cells, and this is part of the ineffective production of mature red cells in thalassemia, for example, and that is what this drug aims to achieve, to develop more mature red cells so that these red cells work more properly and carry the oxygen wherever is needed across the body. So the main goal of the initial study and the vision of around the Reblozyl, previously referred to as luspatercept, was to reduce the transfusion burden by at least 1/3, or 2 red blood cells approximately during a set of 12 weeks. And this was the original study, I believe, of the first 336 adult patients that were separated into those patients that received the drug and those patients that received placebo, that is, that they did not receive the drug. The patients in both arms were allowed to receive best supportive care as needed. They were between 18 to 66 years of age, 50 to 50 approximately males and females, nearly 60% splenectomized, and 31 patients with the severe genotype β-0 mutation. One of the important prerequisites was, of course, that patients were transfusion dependent, receiving approximately 6 red blood cell units every 12 weeks, about 2 per month. So what this showed, and this is where the value of the drug was based, was that 21.4% of these patients were 1 in 5 reduced by 1/3 their transfusion burden. I shouldn't go too much over this because these are what the experts are going to cover, but our patients are concerned about the side effects, the blood clots, the high blood pressure, their splenectomy, their splenectomized status, and these are all very well explained in the authorization leaflet. It cannot be given at home. It must be given by a healthcare professional, and it's an injection under the skin. The doctor, your doctor, is the one that needs to decide on the dose, on the continuation of the drug, on the increase of the dose, of the decrease of the dose, of your discontinuation of the therapy. Is a drug that needs to be under the supervision of your treating doctor. The drug has been given, as we know, authorization both by the USA Regulatory Authority, FDA, on November 2019, followed by the European Medicines, EMA, on the 25th of June. It has been given a priority review by FDA, which means that there was a quick assessment of the drug that was intended to treat a serious disease or condition. This is what priority review stands for in the context of the FDA regulations. And the EMA committee gave a positive opinion to the European Commission, which is the final responsible authorizing body for approving the drug. In Europe, the advanced therapy products are centrally authorized. That means that automatically every European country is authorized to use the drug, have access to the drug. Are studies continuing? Yes, of course, studies are continuing for seeing longer periods, the effectiveness and benefit for longer periods, as seen on the publication, on this reference, benefit of continuing therapy. And studies are continuing and hopefully reaching completion for the NTDD patients, for patients with non-transfusion dependent thalassemias, as is the BEYOND study. The potential benefits as seen by the patient community are, of course, those that are at least obvious to the patients: reduction of transfusion and disease-related iron deposition, the reduction of dependency, of course, on transfusion therapy and attendance to transfusion clinics, the amelioration of TIF concerns and challenges for blood donations and blood adequacy, a very important challenge on an everyday basis for a patient, and of course all the consequences of these reductions, minimizing of transfusion-related infections, adverse reactions, unwanted reactions, and relative to the cost of iron chelation. Now, the questions and concerns posed by the patient community, TIF's perspective. So we would like our international experts to answer some of these questions, or at least discuss them. Who are the patients that could benefit the most, and who should be prioritized in order to facilitate the work of the competent authorities? Competent authorities don't like to see big numbers, would like to see a strategy, would like to see a prioritization kind of program. How is splenectomy addressed in this prioritization process? How are the patients with NTD genotype but currently transfusion dependent considered? Are they considered in this group of patients that for which the drug is already authorized, or are we waiting for the authorization of the use of Reblozyl in NTDs? Are national regulatory authorities well versed on its value and benefit? Are treating physicians well versed on how to select patients, but more importantly, monitor its safety and effectiveness? These are great concerns posed to us. At the moment, the table that TIF put together is that in the greatest majority of countries, the drug is not approved at the country level, and wherever patients are being treated, they're being treated in a few numbers on compassionate programs. Some of the countries approved include Australia, Spain, Germany, and Greece. In the rest of the countries, compassionate use or not at all use of the drug is the norm. Where does TIF focuses? It focuses, of course, on supporting the promotion of access of this drug in every country, particularly in medium and high disease prevalence countries. We are focused on supporting in as many ways as possible within our role to ensure safety and effectiveness. And how does TIF thinks that this can be ensured? We are suggesting post-marketing collection of data. Already the EMA authorization had it under additional monitoring. That means strengthening of monitoring and collection of data. But we need to take it more seriously at every country level. Comprehensive, consistent, and continuous at the national level collection of this data. In Europe, for example, we have the pharmacovigilance, but in other countries of the world, and in some other countries like UK, USA, and Canada, but I'm not sure in developing countries how this arm of pharmacovigilance is practiced, if it exists at all. We feel that there is a need, an urgent need for comprehensive education of treating physicians who are not in reference centers, who are not treating many patients, who do not have facilities around them. So comprehensive education in the use and monitoring. And we are proposing the creation of reference expert hubs at the national country level and an international level, so that they can share experiences and best practices, and these academia can provide expert advice to treating physicians and to governments to support their efforts. What can TIF do? Well, TIF must and is developing its own patient-focused hub for interaction with the global patient community, answering questions, interacting the challenges, passing on these concerns to its international advisory board, collaborate with industry for developing and strengthening, supporting and compassionate programs across, and collaboration and networking with governments through competent authorities for better interaction. The aim is, of course, to achieve better pricing to enable the work of the governments to make it accessible and available to our patients. So the time is to act, and is to act yesterday, I should say, and not now. As global patient community, we need our medical expert interaction and guidance. Should we develop specific recommendations for the use of this drug? Do we need additional or new laboratory testing in our monitoring programs? Do we need additional data? And these are questions and challenges that I would pose and pass on to our international experts. So, Dr. Michael, you can introduce Cabellini, Professor Cabellini for her own. Thank you very much for listening to TIF's perspective. And now we have Nika Cabellini.
Okay, I think everybody knows Professor Maria Domenica Cabellini from Milano. She has contributed a lot to clinical research, and she was a key player in the clinical trials of luspatercept, and we would like to hear from her a summary of what is really known about this drug and what about these patient concerns that Andrula has spoken about. Professor Cabellini.
Okay, thank you very much, Mike, and thank you very much, TIF, for organizing this mainly roundtable. Can you see my slide?
Yes, absolutely.
Okay, so thank you to Dr. Eleftheriou that already introduced and also presented some results of luspatercept. I will try to be as short as possible in order to leave time for the discussion. These are my disclosure. And I always use this cartoon to show that there are different novel targets of treatment for beta-thalassemia. And in the previous webinar, gene therapy has already been discussed. And today we are focusing on targeting ineffective erythropoiesis. So just before moving to luspatercept, I wanted to recall to your attention what ineffective erythropoiesis means and why is so important in thalassemia. So ineffective erythropoiesis is an increased proliferation of erythroid progenitors. So in this slide, you see on the top the normal erythropoiesis, on the bottom the ineffective erythropoiesis, where you can appreciate an expansion of erythroid progenitors. And this implies an increased apoptosis of erythroblast, impair maturation of erythroblast. So the consequence is anemia. So that is the situation. And why this situation is so important in thalassemia is just because due to the unbalance between alpha and beta globin chain, which are the important component of adult hemoglobin, being a defect of beta thalassemia, the main driver, the beta chain, sorry, the main driver, there will be an excess of alpha chain which precipitate causing that. So why luspatercept? Luspatercept, well, I have to say that, of course, many years have been dedicated by different groups to find a way to correct ineffective erythropoiesis. And luspatercept it came around, I should say, by serendipity, which means that it was not really designed and programmed to treat ineffective erythropoiesis. Originally, it has a completely different, let's say, utilization. Was designed to improve osteoporosis in postmenopausal women. And it turned out that it was a erythroid maturation agent. So the erythroblast undergo during treatment with luspatercept to a maturation that neutralizes select TGF-beta superfamily ligands and inhibits this pathway, SMAD2 and SMAD3, enhancing the erythropoiesis. So this molecule is an investigational first in class erythroid maturation agent, which has this function. Someone may ask, but what's different compared to erythropoietin, for example? There is a significant difference because this molecule is acting on the late stage of erythropoiesis, whereas EPO is acting at the beginning. So this is the mechanism of action. So how is the situation? I try to go a bit fast. Since this effect was observed using this molecule, several trials have been designed in humans, particularly in thalassemia, but also in MDS. You see here two molecules, but forget sotatercept, which is very similar, but now is used for other purposes, not for thalassemia. So you see there are two completed phase 2 studies, and then the BELIEVE study, which is in the one Dr. Eleftherio already mentioned, and Beyond, which is in non-transfusion dependent, and a pediatric study, which is just starting to recruit. I summarize in this slide the findings from the two phase 2 trials, and particularly the one on luspatercept. That was almost an exploratory study, also those findings, including either transfusion dependent and non-transfusion dependent patients. And of course, you already know, but I remind you that the treatment is an injection subcutaneously every 21 days, so every 3 weeks. And in transfusion-dependent patients, the first aim was a reduction of transfusion burden of more than 20% compared baseline, and 81 of patients achieved these results. And in non-transfusion dependent patients, the primary endpoint was an increase of almost equal or more than 1.5 gram, which was achieved in 58% of the patients. So with these results prompted the design of a phase 3 clinical trial. I like to show this ancillary observation, which was an improvement of leg ulcers in a couple of patients who were under luspatercept in having a leg ulcer. They improved significantly. So quickly, BELIEVE trial, phase 3, 336 patients, randomized 2:1, plus, of course, best standard of care, and 1 year observation, and then open label, and those on placebo, they could cross over to luspatercept. Primary endpoint achievement, that's are only patients with transfusion-dependent thalassemia, defining transfusion dependency as at least from 6 to 20 units of blood in the 24 weeks prior randomization. The primary endpoint is a reduction of equal or more than 33% from baseline of transfused blood in a fixed period, precisely during week 13 to 24. The secondary endpoint, I'm not going into detail, but where, again, more than 33% in another fixed period, or equal or more than 50% in the same two fixed period. Quickly, because the data are published. Primary endpoint were significantly achieved because a great proportion of treated patients achieved the primary endpoint. And this is probably this slide probably already answered to some of the questions that Dr. Eleftheriou posed, because that was an analysis in subgroups, and all the subgroups were in favor of luspatercept. And what were the subgroup? The ethnicity, the age, less than 32 or more than 32, splenectomy, yes or no, sex, genotype, β0, β0, non β0, β0, and then the amount of blood transfused or unit transfused, the baseline hemoglobin, less than 9, more than 9, liver iron concentration, less than 3, between 3 and 7, or between 7 and 15. So all these subcategories were evaluated and all responded well in the luspatercept group. These are the secondary endpoints, which also were achieved, but I don't want to focus too much on that. I want to focus in a major point. Keep in mind, the design was look at the response in a fixed period. But if we take 10 patients with even transfusion dependent, is even more in non-transfusion dependent, but even in transfusion dependent, the rate of ineffective erythropoiesis cannot be equal in each patient. They may start from different grade of ineffective erythropoiesis. So the evaluation of response is much more consistent if we look at the results at any 12-week interval or any 24-week interval. And you see that the number goes up to 70%. So 70% of the patients achieve the primary endpoint if we look at the response along the year. So this is an important point for physicians, but also for patients. You cannot expect to respond exactly as your peer. You may respond later or you may respond before. The other important issue, which was already mentioned in the subgroup analysis, is the genotype. Definitely the beta plus beta 0 respond, or beta plus respond better than the beta 0. But even the beta 0 had a very good response. And that was, let's move to safety, because we will discuss that in more detail during the round table. In general, you can see that adverse events of any grade were exactly similar in the two groups, okay? Probably a grade 3 adverse event were more common in luspatercept cohort than in placebo, but I have to say that all were manageable, appearing at the beginning of treatment without major concern, as well as the serious adverse event, which once again I mentioned were manageable. There is a point which I know that is very much, well, these are in more detail, this kind of adverse event, bone pain, arthralgia, dizziness. But there is one point that I know is very much concerning the patients, and that is an increased risk of thrombosis. So in the luspatercept group, for this trial, believe, not for the others, 7 patients had thrombotic events. No one was responsible of death or no significant risk. And I have to state that analyzing case by case of these 7, all of them had previous thrombotic event and high score risk for thrombotic events. So that has to be taken into account. So I'm going to conclude for believe because the results were positive, consistent, and that's allowed the registration, as Dr. Eleftheriou already said. There are other sub-analysis, for example, the quality of life, which was of course in favor of luspatercept patients. There was also for long-term observation. Here we go more longer than previous observation, and there a sustained reduction in red blood cell transfusion was observed. These are data which were presented at ASH last year, and I want just to finish with that, the iron overload. The risk of iron-related complication was evaluated by stratifying patients into categories based on serum ferritin, less than 1,000 to 1,000 or to 2,000.5, and based on liver iron concentration. So if you focus on the top of the graph, you can see that the column of treated patients, the dark column, were treated patients who started with baseline serum ferritin higher than 1,000, and then a large percentage of them move to less than 1,000. Look, for example, at week 7396, a high percentage of treated patients achieve level of ferritin below 1,000, having started with more than 1,000. And this is also for those who started with 2,500, and although slowly, but is observed also for liver iron concentration. What is this? This is the design of the Beyond trial, which is in non-transfusion dependent thalassemia patients, whose primary endpoint was a proportion of patients with the increase in hemoglobin concentration of more than 1 gram in absence of RBC transfusion from week 13 to 24 versus baseline. And the secondary endpoint was a quality of life. What can I say for that? The papers have been submitted to FDA a couple of weeks ago with the results, which are very consistent and very positive, but of course I cannot yet present. What have we done in Italy? We started a compassionate program, which was from November 2020 to May 2021. We enroll more than 200 patients at present. When I prepared the slide, were 138. But I have to say that we are elaborating these results. But 1 week ago, AIFA, the Italian agency, approve the luspatercept. So we are just waiting for marketing. And of course, I really thank all the patients, family, and all the investigators all over the world who participated to this program, and all my collaborators in Milan. And I take any question during the roundtable.
Can I moderate?
Okay. As questions begin to come in, let me ask you one or two questions. And this is not just for Professor Cabellini, but also for the other medical experts who know the drug more intimately. The kind of question that comes to TIF from patients, as you rightly said, the main concern seems to be the thrombotic effects. And if a patient is splenectomized, how do you follow that patient to ensure that a thrombotic event does not happen? This is question number one. The other question that is quite frequent seems to be concerns about infertility, which perhaps needs a little bit more elaboration. But I would certainly like to hear some discussion on how do we monitor patients who are splenectomized and have started luspatercept.
I want to start, but I will be short, and I'd like to hear the others. First of all, this is a general problem for thalassemia patients. Splenectomized patients are at higher risk of thrombosis, and this is particularly true for non-transfusion dependent thalassemia patients, because among the several factors which could be responsible of increased thrombotic risk, there is also the huge amount of erythroblast present in peripheral blood. And these erythroblasts actually behave like platelets because they expose phosphatidylserine. This is a general comment. Okay, so usually based also on some huge survey, thrombotic events are less frequent in regularly transfused patients for the reason we mentioned, less erythroblast in peripheral blood. If they are splenectomized, of course, they have high level of platelet, but that's not really sufficient to explain the thrombosis, and are less frequent. Just surprisingly, I'm talking of clinical trials. We observe 7 cases in transfusion-dependent trial, no a single case in non-transfusion dependent, no single case in MDS. So I don't want to be tranchant, but I would say that probably those 7 patients should have been considered more carefully at the beginning before starting luspatercept. That's my opinion. John, or the others, sorry.
Professor Porter, unmute yourself, please.
Hello, can you hear me now? Thank you. Yeah, so thank you for asking me. I think there are issues which are theoretical and those which are practical. And the theoretical ones are not small, and I think they're highly relevant to selection of patients. So if you take any drug which allows the patient to survive on their own red cells rather than non-transfused red cells, you're going to be in an increased thrombotic, prothrombotic state. And whereas in the non-transfused patients, they're already surviving on their red cells. So if they were going to get a thrombosis, they probably developed that. So I can think of several of my patients who we put on transfusion because they were getting thromboses. And if we were then to take them off, go onto a new drug, there would be, to me, a theoretical risk of thrombosis. So Andrula asked at the beginning, how do we select our patients? Yes, splenectomy may be one of them. 2, previous history of thrombosis most certainly would be one. And so if you've got a patient who had previous thromboses and who we've started on regular transfusions for that reason, it would seem to me questionable whether you want to reverse that process with any drug. So, but I mean, that's a big question, and I'd be interested in what other people think about that. There are other safety issues which I could bring up, but I think we'll stick to that point for the moment. I mean, it was striking that the thrombotic and prothrombotic events were markedly more noticeable in the luspatercept arm than in the treatment arm, and than in the placebo arm. So I'm not sure it's a direct effect of luspatercept. I think it's more likely to be due to a process whereby you run people on their own red cells, which express phosphatidylserine and are marginally more prothrombotic.
It's very interesting.
Sorry, I just wonder whether Vip can actually comment, because he has many more non-transfusion dependent thalassemia patients, and maybe his experience with luspatercept in these patients might be different.
Unmute yourself, please.
Sorry. Thank you very much, Michael. And I totally agree for what Professor Cappellini and Professor Porter said regarding the pathophysiology of thrombotic development in TDT and NTDT patient. And of course, we increase the probability of the prothrombotic events because of the flip-flop phenomenon of the red blood cell. Especially the risk will increase in the splenectomized patient. In our experience with the NTDT, we did not observe any one of our patients who developed the thrombosis during the course of luspatercept. Okay, even in the TDT trial that we enroll around 50 patients into the BELIEVE trial. And I think one of the important factors, which I'm about to say, is the genetic risk, because in the Asia, we don't have the prothrombotic genetic risk, such as the factor V Leiden and or the antithrombin variation and so on. So I think that can be another factor that you might take into consideration of the family history of thrombosis and the genetic risk. As a consideration for the use of luspatercept, even though I don't have any strong scientific evidence from the BELIEVE trial, because I don't think that we have analyzed such a factor in 7 cases. I don't know, maybe Nika know about some of these information than me.
Sorry, couple of them had coagulation abnormality screening done, and if I remember correctly, but I cannot, I don't want to, one had the homocysteine mutation, and one had the factor V Leiden. I want to add one point that we didn't mention among the risk factor, anticonception. So the ladies taking the pills for anticonceptional, they increase the risk of thrombosis, and that has to be taken into account. But not, and personally, I don't believe that is necessary to perform a coagulation abnormality screening to any patient starting luspatercept. I mean, there is no reason and no meaning.
Yeah, I agree with you, Nika. I just try to understand why we observe less the thrombotic events in the Asian population. And I think one of the factors which is very, very rare is the genetic predisposition. But I think the family history would be something that we can determine in the patient who we are going to start the luspatercept.
I was hoping for some questions from the audience, from the patients.
The other questions that you noted down from the patients? Fertility was covered, thrombosis was covered. Professor Cabellini, you have mentioned the trial on children on the younger ages. What ages are?
Vipe knows better because you are probably involved. So he knows the trial was actually starting the enrollment before the COVID era and then was stopped for that. And to my knowledge, is starting to enroll. VP, you may be more.
Yes, thank you very much, Nika. So this is the 004 study, and this is in pediatric population. The study has been delayed because of the COVID-19, but we are about to, reboot the study again. So we will divide the study into two different cohorts, and this is the phase 2 study. In the part A of the cohort, we will start with the patient from 12 to 18. Okay, and we will divide. And the first part will be like a dose adjusting because we have no experience of using luspatercept in patient under 18, and so this will be the first study to do that. And we will start to do the dose finding study to see their efficacy and also the adverse event of the luspatercept. And followed by the dose escalating study. So after we finish the part A, that we happy with the safety monitoring team and all the adverse event and acceptable efficacy and so on, we move to the part B, which will go a little bit younger to as young as 6 years of age. So I think that. But the result will not be ready. The part A, first part, maybe next year. Hopefully by EHA, we might have some of the data to share.
Actually, I don't want this to be a conversation just between doctors.
Yeah.
So thank you, Maria, for lifting your hand. Let's hear from you first.
Yeah, and also some other questions on the screen. Yeah.
Hi everyone. Maria from New York. I have been on luspatercept from April 2020. I wasn't going to go on it because of the blood clots. That was my biggest concern since I removed my spleen at age 9. But because of the lockdowns, we had very little blood supply in our blood banks, and I wanted to move forward in life, not depending on blood as much. My main decision why I went on luspatercept, and it is life-changing. I have went from 2 pints of blood every 14 days to 1 pint of blood every 3 weeks. Sometimes I even go every month. And by November 2020, my ferritin went down to a 500. So I stopped, my hematologist stopped my desferal. I'm only on 1 chelator, Ferroprox, which has been an amazing oral chelator for 20 years in my life now. I do want to say 2 things. When patients call me, because I'm very active in the patient community, what is my journey with luspatercept, I tell them, take your time. You're not going to see the jump from the first injection. A lot of patients are like, oh, I haven't seen it, my 3rd injection. I haven't seen it, a good jump until the 5th injection. take your time, be patient with it, and listen to your body. If your body is going through back pain, bone pain, if you can, take a nap. Listen to your body, be good to your body. So these two things, key takeaways that I went through it, the first few months was very important. Thank you.
Sorry, Maria, just before you leave, have you had your spleen removed?
Yes,
when I was 9 years old.
Yeah.
Okay.
Yes.
But thank you very much, Maria, because
You're welcome.
You've given the patient's perspective, because the patient is interested on moving forward, on interacting and improving the quality of life. But of course, this happens in some of the countries that everything else is provided for. And, you know, as an international federation, we are concerned outside those countries where, you know, everything is provided. But, you know, when I hear Maria, I'm just hearing the patient's perspective in its full extent. Thank you so much. Let's take some other questions by patients before we go to the main real question on behalf of our board members and the Thalassemia International Federation, which is a very important question related to regulatory authorities. Was any patient already on aspirin prophylaxis, and did any of those suffer from a thrombotic event during the study? Can we ask those that were involved in the... So was anyone...
Some patients were on aspirin because they were splenectomized and they have had a high level of platelets, and they keep ongoing. This story of aspirin, unfortunately, is not yet, not related to luspatercept in general, is not yet well standardized. Some physician gave after when the patient has 700,000 platelets, some less than so. Anyway, some patients were on aspirin. By chance, they had no thrombotic event, but I cannot say, I don't know what the other things, that this was due to the fact of being on aspirin. It's just by chance. To my, I mean, I try to remind all the data, but no one was on aspirin on those who had thrombotic event. And some of the treated patients were on aspirin. Do you remember something more, John or Vip?
Unmute, please.
Yeah, I couldn't find that in the paper. So the question I wanted to ask was, of the people who got thrombosis, how many were on aspirin? You said none.
None.
Were not for sure.
Yeah.
Other were on aspirin and they came on going on aspirin. And if I remember correctly, no, I think I remember correctly, the final suggestion is to evaluate before entering a patient on luspatercept, to evaluate family history, previous thrombotic events, all the risk factors, and if they are on treatment already, they can, the treatment for thrombosis, they can continue to be on treatment.
Okay, thank you. Another question is, oh, sorry, Vip, so. Yeah.
In my patient, I remember that around 3 or 4 of them already on aspirin, but that because of the platelet count, which is based on the indication of the persistent thrombocytosis after the splenectomy. However, they did not develop the thrombosis during the course of the luspatercept. I don't think that, you know, is we should recommend the use of aspirin as a prophylaxis to the patient who want to go on the luspatercept. We don't have the evidence enough for that. So I think
absolutely.
Yeah.
Absolutely.
Could I ask Nika and Vip what they would do now if a patient comes to you and says, I've got transfusion-dependent thalassemia, and I would like to try luspatercept, and they have a history of significant previous thrombosis. What would you say to them?
Well, first of all, if they have a consistent history of thrombosis, which may means repeated episode, first of all, I will evaluate which kind of treatment they are doing for thrombosis, because this is another point to consider. And I will decide on individual base, patient by patient. I say that if a patient has already repeated episode, I have some concern to start treating the patients.
Yes.
And I think those who had recurrent thrombosis,
That's
will
what,
be on thromboprophylaxis anyway, really. So, you know, it's unlikely to have somebody with recurrent. It's unlikely, I mean, not impossible, but it's unlikely to have somebody with recurrent, unprovoked VTE who is not on thromboprophylaxis. So I think that I think perhaps the biggest dilemma is those who haven't had previous VTE, are not on thromboprophylaxis, but have risk factors for VTE. And you're contemplating to put them on luspatercept. I think that would be my main question, what to do with them, rather than those with previous history of recurrent VTEs who would have been on thromboprophylaxis anyway.
yeah, not always. In some countries, unfortunately, this is not yet well established. But I agree with you, Perla. Those you mentioned are the more difficult to decide. However, if you don't have clear evidences of thrombotic risk, I don't see why not to start. What is important is to monitor this patient.
Yes.
Because if the patient is living in a remote village, it has a peripheral thrombosis, nobody care, not surprised if it goes to pulmonary emboli, nobody care. So this is important issue. To educate physicians, but also to educate the patients. If you have any initial sign or symptom, you have to refer to your center.
Yes, Nika, because it may not only happen in rural areas. It has happened, as we all know, somewhere in a very robust healthcare. So, yeah.
So what would you advise? What would you advise, Vip? What would you do?
Unmute, please, Vip.
Sorry. I totally agree with Nika. I think it has to be a personalized decision based on the severity of the previous thrombosis that the patient have, the treatment that the patient have, or whether it's on the low molecular weight heparins or just the anticoagulant so I think this has to be a discussion, but I think the previous history of thrombosis is not contraindication for the use of luspatercept. Yeah.
Right. So another question comes. What about side effects on fertility in the patients treated in compassionate programs up to now? I suppose some patients who are on compassionate programs now have not been informed of any fertility impact of the drug, and the patients are concerned, saying, what about side effects on fertility in patients now being treated in compassionate programs? I think Nika has a very big compassionate program, yes? Unmute, please.
Okay. Differently than for sotatercept, luspatercept has much less impact on fertility. Okay, so well, I want to ask John, who probably knows, Vip knows more about the preclinical study on fertility, but to my knowledge, luspatercept is not impacting as it was sotatercept. Do you have any more information?
Professor Porter?
As I recall, that was one of the main reasons that luspatercept was chosen above sotatercept, because there's less theoretical risk of fertility issues. But I know of no clinical data. And also, I'm not sure what we're advising about if a couple say they want to get, if a woman says she wants to get pregnant, or a man says he wants to get his wife pregnant, what is our advice about stopping luspatercept prior to that process?
That's a great question, what to tell to the couple. I mean, this is...
So regarding the fertility, I just want to confirm what John said, that the luspatercept had less the aromatase inhibitor effect compared to sotatercept. So I think that's one of the very important reasons that it's been selected to do for the study in thalassemia. We have experience of 3 patients who can perfectly conceive after the use of luspatercept. 2 patients, because of an accident during the belief trial, the patient got pregnant. Okay, so they have to be out from the trial, 1 boy and 1 girl. Another patient who have been joined in Beyond Trial, which is the NTDT, and she has a fantastic response to luspatercept. But before we entering into the COVID-19, she decided to get married and having a children. So she has to be quit from the clinical trial. So I advised her to stay with contraception for 3 months after the stop of luspatercept, and you know, as soon as after 3 months, she conceived with a very beautiful girl, and I just saw her just last week. This beautiful girl is nearly a year now, and she's perfectly well. So based on this experience, because in the clinical trial, both Believe and Beyond Trial, we have to strictly do a contraception, okay? So we cannot allow the patient to conceive, okay? But, you know, we have 2 accidents in the Believe trial because of the condom leak and something like that, okay? So I think that just carrying our experience, but based on the registration, we still recommend not to conceive during the use of luspatercept because we don't know the effect on the fetal anomalies.
And we think that a 3-month washout is a reasonable period. Do we agree on that?
I don't know. This is just based on my experience, and I just told my patient, you know, at least 3 months, you know, try to. But because they are very fertile.
So with new drugs, there's some disagreement about a suitable washout period. Different people say different things. Personally, I think 3 months is reasonable.
Andrula, if I may.
Yes, I was just going to come to you, Sodirula. Where are you?
I'm here.
Good.
Hello.
Sodirula Christou from Cyprus.
Yes, hello to everyone. Happy to see you. I just wanted to raise the question about the bone marrow activity. Hi, we don't have a lot of experience with luspatercept, but we have noticed that the 2-3 patients who are using it, they were presented with a very high number of normoblasts. And so what do you think about the bone marrow activity, the bone marrow expansion?
Professor Porter?
Well, it's a very interesting question. And I think my colleague Maja Gawaski has been looking at some of the biomarkers with time. And there is a suggestion of increased marrow activity in increased size of the erythron. And of course, that could become an issue if it became progressive. I think there's not enough data at the moment. In the short term, there's no clear signals, but in the longer term, there might be. Because of what we're doing is we're stopping a lot of the early erythroid cells dying, and that could lead to increased erythroid masses. But I think on the trial, Nikki, you can correct me, that there wasn't a clear signal on that.
No, as you said, there was no signal. And in theory, I'm expecting that is a kind of, let's say, is a kind of volano, which means that at the beginning, as Soterula said, there is an increased orthochromatic erythroblast, but then this goes through maturation. So I figure out what it can happen. It will be interesting to have, of course, a bone marrow biopsy and see what happens. But I'm expecting that the body of red cells increase progressively with mature cells. So at the beginning, the orthochromatic erythroblast will increase. Then the maturation population increase, and you reach a balance where probably the situation is almost stable with a limited number of erythroblasts going on through. I don't say that it goes to the level of normal erythropoiesis, but there should be a balance at one point.
So I think the discussion has turned very much towards medical, on the medical side, and it all reveals and confirms a concern that there's a lot of data and information needed to be collected post-authorization in order to make more focused and targeted decisions, because even amongst your international experience and participation in the actual clinical trials, you have interactions, dilemmas, concerns, and therefore not concerns about the value and efficacy, but concerns about what to advise or how to select. Therefore, I think one of the suggestions of TIF is the collection of post-authorization data and the creation of hubs of experts to actually guide treating physicians, Nika, not just in the rural area, but
No, I totally agree.
Treating physicians is very important.
I think that this should be done on the two lines: education of physician, because
Yes.
we have to learn how to use. I mean, I'm learning day by day, and nothing is standardized. So how to manage, how to select patients, and on the other hand, to educate also patients.
How to report, how to interact with the doctor.
Exactly.
We are managing
and not be in rush. I really appreciate Maria.
Yes,
because actually it's important. Unfortunately, I have to apologize, but I have another overlapping commitment. I will be available to answer any question via email or.
We are very thankful, Nika, and thank you very much again. Please have a good day and a good
thank you very much.
Meeting wherever you're going. And we have another two experts with us to carry out. Thank you so much.
Thank you.
I think we take on Riyad Elbar, the member of our board, a very long supporter. Riyad.
Thank you, Angela. Hello, everyone. My question is that here in Canada, because we don't really have any concerns in terms of the blood supply, so patients are well transfused, have abundance of blood, knock on wood, we haven't been affected in that regards. The concerns I'm getting from a lot of patients, or the hesitation, is why would I start this medication? You know, how is it going to impact my quality of life? Is it going to affect my hemoglobin levels? Is it going to affect, if I'm going to go through pain, through risks of thrombosis or other side effects. So these are the things we are dealing with. Why would I want to start this medication if it's going to impact my quality of life? Does it affect my hemoglobin levels? Will it really put me at high risk? So these are the things we are dealing with. It's been approved by Health Canada. We haven't got the funding approval yet, but that's something that's in the process. So hopefully we'll get that.
A clear question from Riyadh, coming from a country with robust healthcare infrastructure, no problems on blood adequacy and safety. So there are concerns. Professor Porter, how can you answer this?
Okay, so the questions you raise is obviously very similar to the questions that will be raised in the UK, because there's a similar healthcare system. I think it's a case-by-case basis. I think to some people, the frequency at which they come up for their blood transfusions or the volume of blood they receive on each of those occasions is not important to them. On other patients, it is important. They want to come up less often. And so that is part of the consultation process. If a patient says, look, I'm really fed up, I come up far too much, I'm having difficulty with myculation, that's the sort of patient that's more likely to benefit. Whereas if the patient is quite easily plugged into regular transfusion and chelation, well, maybe the case for changing or adding luspatercept is less strong.
Yeah. Thank you. Vidya, do you have to add anything or?
Something to add, and first I want to appreciate Maria's testimonial comments earlier. I follow you on your Facebook, Maria. Thank you very much. And I think that's a very, very important question, how luspatercept can affect my quality of life. Because if you don't have any issue about the transfusion accessibility or the safety of the blood, I think this is most matter issue if you want to use the luspatercept, especially for transfusion-dependent thalassemia or TDT. Mm-hmm. So in my experience in the clinical trial, my patient population seemed to be a bit younger. Yeah. Because most of my patient is under 35 years of age. Okay, so this is just my transition clinic that from pediatric to young adult. So talking to my patient, I would say, because most of my patients are beta-thalassaemia E, and if you remember from the previous presentation by Professor Cappellini, they respond so well, and they have like something like 71% of the increase of the hemoglobin. And we have further analysis in e-thal, are up to 65% of them reduce transfusion requirement by 50%. And talking to my patient, one of my patients who was a young boy, he's around 20-something, and he told me he can play football for the whole games without interrupting and sitting at the sides, which is, he said, it's never happened in his life before. And of course, this is after the reduction of the unit. Instead of giving him like 3 units, I just give him 1 unit or 2 units. So I think this is something very individual for different people. And I think it will benefit, especially in the younger age group of the patient, because they want more time for their life, their work, and their family.
Very individual. Thank you very much. Mrs. Julie, would you like to comment? That's the board members. Mrs. Julie.
Hello, everyone. I would just like to say, of course, it's a very educative and informative session and webinar, and I've been listening it very thoroughly. I just want to know that if, because in Thailand, of course, the trials are there and all that, any possibility that such kind of trials on this drug can be spread to the other parts of the country, or they will wait and then think about that after looking at the further results? Are there any plans to take these trials further to any other countries?
Okay, of course, the experts will answer, but the drug is authorized, Mrs. Chuli, you know, by FDA. So, and by EMA centrally. So if your authorities are actually adopting FDA's approval, then the drug is there for you. And it's the responsibility of the government and your competent authorities to actually make it available. So clinical trials are only ongoing on MTDDs to be completed, but for the transfusion dependent, the drug is authorized.
Is there any possibility that, because what I understand is that it's more effective for the non-transfusion dependent patients,
maybe more beneficial,
that TIF can prepare a document, you know, and give it to the board members or to the other, you know, the leaders in their countries and all that, so that they can take those papers to their governments to convince them that this is the, and is it there is this possibility is there? Can we do that?
You're asking TIF?
Yes.
Yes, of course. We already put it in the board members update, and we have developed the e-academy, the Access e-academy, and the program exactly to support the information available, reliable and published information from this trial on the benefit, on the value, so that governments can be supported in their decisions. But it does need the doctors, the treating doctors, healthcare professionals and patient communities to actually act together. When we will do that, it's in the program, Mrs. Chuli, you know, but we have seen with Michael, for example, the decision of the French government, and we're not aware of the decision of the NICE government, of the NICE health technology assessment in the UK, for example, which are very strong health technology countries with health technology assessment. I'm not sure, John, if NICE has issued any decision on the use of luspatercept.
Well, there's no update. It's on hold, and there's no immediate prospect of it being made available to transfusion-dependent patients.
I'm only asking this because NICE's responses and the process affect very much and influence the decisions of other governments. As far as TIF is concerned, we have a very structured program, and we have been all along very productively and meaningfully collaborating with the industry through the clinical trials, providing the patient's perspective. Therefore, we're on a good track. Johari, Mrs. Johari and Mrs. Manal, unmute yourselves, please. Thank you.
Hello, everyone. I'm Fazalina from Malaysia. Okay, I just share my experience because I'm one of the patients for BELIEF study. I started taking luspatercept since September 2016. I just want to answer Riyad's question because yes, it's helped a lot, improve my quality of life. And then what I can share is that, but I withdrew last year due to some medical issue. So I taking luspatercept about 4 years. And during the trial, I can say my HB is, okay, interval week is every 3 weeks. Before this, I transfuse every 1 month, 2 units of blood. And then after I'm taking luspatercept, I transfuse every 3 weeks with 1 unit of blood only. And then my serum ferritin dropped a lot. Before this, my ferritin is always 1,500. But since I joined BELIEF study, my ferritin always 200 to 500. So it's maintained even until now, even I'm no longer in the BELIEF study. So, and then during my trial, I also quite active because my HB is very high and it depends with my doses because sometimes the doctor take times to know which is the best dose for the patient. So once they know the best dose, I mean, they can maintain the HB. So mine is always 10.5 and sometimes it can be 11. So I always do always do like activities such as hiking, running, Zumba. So it's helped a lot in quality of life.
Yeah, your quality of life. Thank you so
Yes,
much.
a lot.
Yeah. Thank you so much. This is what we need to hear, is like experiences over a long period of time. Like you've been on it for 5 years.
5 years. Yeah.
Yeah. Excellent. Thank you. And thanks to the expert panel.
Thank you for sharing this. Manal.
I want to say you just echoing for what I heard from my patient. I'm very glad to hear that, because all of my patients said the same, who've been in part of the trial. They are very, very happy.
Intermediate, Mikhali Johari? Johari is intermediate? No. Transfusion dependent. Johari, you are intermediate or transfusion dependent?
Transfusion dependence.
Okay, thank you. Manal from Egypt.
Yes, hello, everyone. I have a question. It was mentioned that in the non-transfusion dependent patients, luspatercept increased the hemoglobin by around 1.5 grams. This result is the same when non-transfusion or in some thalassemia intermedia who are using the hydroxyurea hydra. So from the point of view of the patient, how can the patient decide which drug to use when both have the same result?
So anyone going to answer that?
John, you can go first.
Okay. So that's a good question. What struck me about this study in the non-transfused, so in the Beyond study, was the relative consistency of response. So the average increase in hemoglobin was about 1 to 1.5 grams. Now there was variability. Some people increased by 4 grams or 5 grams even, and some didn't increase at all. But the variability, in my experience, was less than with hydroxyurea. With hydroxyurea, some patients don't respond at all, and some patients respond a bit. So I think that one of the big advantages of this drug is it's been properly studied prospectively in a randomized trial. The data with hydroxyurea is small studies from different centers with poorly chosen patients, and it's very, very difficult to pick up a clear picture. So one of the big advantages of this drug is the way it's been studied. I think you can probably use the two drugs together. And so in the sotatercept studies, we had patients on hydroxyurea already, and when we added sotatercept, we got an additional effect. So my feeling is not an either or. And once you're off the trial, you know, the doctors, with discussion with yourselves, can decide, well, maybe we can go one better. And there's absolutely no reason you can't mix these drugs.
Yes, I agree with you, John. And the way that we decided Beyond trial, we not allow the patient in the hydroxyurea into the trial. But you know, after it has been registered and become in the clinical use, it will be a compassionate approach, depending on again different patient and the response to the combination therapy of hydrea and luspatercept. And also, I think, you know, these two drugs may affect on the different mechanism, you know, by attacking on the different pathway, I guess. So I think the synergistic effect can be expected when we use it in combination. But so far, there is no comprehensive scientific data on the study yet. So this may be something that we can do later on after it got the approval.
Okay.
Piece of new information. Yes, Manal.
So if, for example, what I understand that some patients were on a combination therapy between luspatercept and hydra. So can this like lower the pain of the bone pain, since hydroxyurea works on inhibiting the activity of bone marrow?
So the combination was sotatercept and hydroxyurea, not luspatercept. So on the Beyond study, you weren't allowed to take hydroxyurea. But I mean, that's a detail. In terms of bone pain, yeah, I mean, I think it's possible that you might be able to control bone pain by adding hydroxyurea to someone who's on luspatercept. We do that anyway for patients with non-transfusion dependent thalassemia who are getting bone pain. We give hydroxyurea, and sometimes that improves the bone pain if it's due to EMH or intramedullary expansion. That has a potential use.
Thank you. Thank you. Please note that this is a discussion, and for patients it's not advisable to take up this as, you know, instructions or recommendations. We are discussing your concerns with the international experts, and perhaps we'll have some minutes later on and follow up data to have more focused recommendations. We have Professor Paul Telfer on raising his hand. Paul, good afternoon.
Yeah, hello there. Can you hear me all right?
Yes, very well.
Oh, good, because my microphone's been playing up for the past week. So I came in rather late to this discussion, but I just had a point to follow up with Mrs. Tooley's comment about further trials relevant to people living in developing economy countries where thalassemia is very prevalent, and also where the blood supply is often very challenging. And I think that, you know, we think about clinical trials in terms of phase 1, phase 2, phase 3, but we should also think about more sort of healthcare intervention on a public health level. And I think there is a question here about, for instance, in Thailand, Bangladesh, etc., where ethal is common and where luspatercept seems to be quite beneficial. Whether these countries who are developing their blood transfusion services should concentrate on a drug product that might replace the need for a vast expansion of their blood transfusion industry. And that's a different kind of trial and requires not only clinical, but also health economic considerations. And I think it's something that maybe could be quite important in India, Bangladesh, Thailand.
Paul, you have raised a very important point. I mean, we're all thinking of clinical trials in the context of phases and authorizing a drug, but it could be clinical studies in countries like India and countries in the developing part of the world where blood adequacy is a major challenge. Yes, indeed. I don't know how this could be taken up, but I'm sure we can see how we can put some recommendations together with academics and industry and health economics, because that would be a point of, you know, of the governments facilitating their decision on saving lives, for that matter, in terms of blood.
Actually, there's the issue of safety of blood as well. In some
countries. Not only adequacy.
And certainly if it can be replaced, of course, affordability comes into this.
Okay, that's a very good, we note it down to see how we can sort of promote such a, I think we need a question from Helen Jabres from Canada. Thank you for this workshop. In Canada, Reblozyl was approved on February 16th, 2021. But since then, only 2 to 4 patients have started. My concern, since Helen, who belongs to the Canadian Association, together with Riyadh, so 2 to 4 patients have started. My concern is that the protocol calls for patients who have removed their spleen have to take a blood thinner. What would be the side effects of taking this medication over time? Also, should patients be concerned about hypertension and high blood pressure developing? Professor Porter, would you like me to repeat the question?
No, it's fine. I'm turning my microphone on. I'm interested to hear that in Canada, if I understood what you just said, that people going on to luspatercept who have had a splenectomy are required to take some form of blood thinner.
Blood thinner.
What is that, aspirin, or is that more than that?
Probably Helen doesn't write. It's probably aspirin. I don't know.
Aspirin's fairly simple, but if it was more than that, I could see it would discourage people. But I mean, it's relevant. The conversation we were having earlier, I asked Nick and I asked Vip what they would do to someone who's got a history of thrombosis. But I mean, the other question was, well, what would you do? Would you treat splenectomized patients differently from non-splenectomized patients with respect to going on to luspatercept? Vip, do you have a different attitude?
No, I don't think so. I think, you know, even the patient have been splenectomized and been on the, let's say, the aspirin. So it should not prohibit the patient on taking their benefit of luspatercept. So I think, you know, as we discussed earlier, that there's developing of the thrombosis in the trial involves several other factors, and it has to be thoroughly discussed between physician and the patient about the benefit and the risk to getting the thrombosis. So for me, because none of my patients got thrombosis, I would say I have very little concern regarding the thrombosis after the use of luspatercept. And this is just my personal experience, and I think also in other Asian countries as well.
Thank you. Can we go to some of the next? How can we advocate for long-term treatment for patients enrolled in clinical trials when the trial ends and the drug is not accessible to patients? This is a common challenge, always coming up with the completion of the clinical trials, and then patients stop taking the drug. They're not being given. So how can we advocate for long-term treatment? That's a big challenge being discussed at the European level as well. Please, Professor.
Can I say something about this? Just follow to this question, and I will continue with a suggestion by Paul. In Asia, we are about to get approval in Thailand and in Singapore as the first two countries for the luspatercept by early next year, by the Q1 of 2022. Okay. And I think Malaysia will be the other country that will follow maybe in the Q2 of next year. One of the things that I have already discussed with the industry is to set up some kind of patient access program. So actually this kind of the program now is already available in countries like Thailand. So they allow us to submit the patient that we think as a physician that will benefit from the luspatercept, of course, in the TDT, because this is the FDA approved, EMEA to get a free access to luspatercept. Okay, we about to set up this program for the patient in Thailand, but unfortunately the COVID came in, and you know it's just chaotic, and the hospital closed, you know, for the COVID mainly. So we haven't really started this kind of patient assist or patient access program yet. But hopefully by, you know, nearly the end of this year, we can restart this kind of the activities for the patient. So I think the similar thing can occur in the other country as well. So I think you can try to contact the industry, BMS, about this kind of program to get this accessibility. So this is just my suggestion. The other thing that I want to comment about Paul's comment about the developing countries. I used to think that, you know, Thailand have very strong blood supply services and facilities, but I have to say I was wrong, especially in the COVID-19. We have a big shortage of blood donation and blood supply to our patient. You know, we suffer a lot. The patient usually have like 3 units. We have to cut it down to 1 unit because of the shortage of blood supply. So I think it's just a very good example that, why luspatercept might be very useful for, developing country where we may have a vulnerability of the blood supply shortage because of the other factors. So I think, but how can we do this kind of, study? Maybe, we throw the ball back to you, Angela.
Yes, these are two different things. One is, of course, the clinical studies in the countries with huge challenges in blood adequacy and safety, and the other is the continuation of patients to free access after the completion of the clinical trials. And well done, and congratulations for achieving them in Thailand. In Europe, there has been an attempt to do that. But we need more collaboration of countries, perhaps to give bigger numbers to industries and, have the industry some anticipation of the numbers of patients to be enrolled so that they can actually think more seriously of providing programs for free access. This has been done in Europe in a kind of Valletta alliance or the Benelux alliance, where ministers of health, unite their efforts and talk with the industry for this. But it is very important for those that are on trial to be assessed and continue for free access. It's a major focus for us as well at TIF, and we'll see how we'll take it further. Thank you. The other one is from Michelle. Where is Michelle? Michelle from Lebanon, Chronic Care Center, a member of the board. Is the fertility issue reversible? After which time after stopping luspatercept, infertility issue will be resolved? But of course, John?
Well, that assumes there is infertility, and I'm not aware of any data that there is. With sotatercept, there was data in mice, but not with luspatercept. There is an advice that because it's a new drug, that we should be careful to stop treatment 3 months at least before trying to conceive. But that's, it's not evidence-based, that's just a precaution.
A precaution and an advice. So there is no evidence, Michelle, on this, on the impact on fertility. It's an advice that is written also in the authorization leaflet of the drug 3 months before. Bone pain.
That also based on our first-hand experience in our patient as well. So I don't see any issue regarding the infertility in the patient who've been on luspatercept, both in TDT and NTDT.
That's very good. Very release the concerns of the patients. Bone usually occurs on day 2 to 3 post-injection and lasts for a few days. Few occurs on the next day. Okay, this is a statement. Dr. Perla Eleftheriou says that in Spain, luspatercept is not yet approved. At this moment,
I didn't say that, I'm sorry.
Oh, yeah, who says that? Oh, Ana Villegas, I'm sorry. Yeah, it says Dr. Perla. So, from Ana Villegas, thank you very much, Dr. Villegas, for being with us. In Spain, luspatercept is not yet approved. At this moment, we are making the therapeutic positioning index. On a compassionate program, we have 15 patients. Okay, that's good because Europe started to move. From Monica Kreka, we are very willing to start any compassionate program in Albania with luspatercept. Till now, it has not possible. I think it's a big effort we need to put across the world. What will be the consequences if patient taking the drug with regular transfusion regime or who are non-transfusion dependent thalassemia with around hemoglobin 9? Vip?
Oh, okay. So the question is about the NTDT patient, right? if I understand correctly. So it's based on, I think it's based on the registration in the country. Now luspatercept is not registered yet for the NTDT. So we cannot use it for the NTDT outside the clinical trial. Okay, so I think we have to stick with that. It's under the process with the FDA approval. Okay, so I'm waiting for the email. Maybe they may have some to visit Thailand and interview me for this indication. So at present for the NTDT, you cannot use the luspatercept. Okay, so that's one thing. But if you got the TDT patient who received irregular transfusion, so I think that's not really lie with the TDT definition anyway. So it's maybe the NTDT who received regular blood transfusion by any indication, for example, EMH or whatever, okay, or primary hypertension. So they can be eligible to receive luspatercept, I think, because of the current regular blood transfusion that they receive. So I think they will respond well, because in that circumstances, bone marrow activities is probably not completely shut down, and they still be able to benefit from the erythroid maturation effect of luspatercept. I don't know. What do you think, John?
I'm not so sure. Yeah, I think if you've got a history of EMH with significant expansion in places you don't want it, I am nervous about reducing the transfusion frequency and allowing a greater autonomous erythroid drive by giving luspatercept. I think it's got a case-by-case basis, but I think to assume that it's a benign intervention would be wrong.
So there we have, I'm really more and more worried as I hear our medical experts here, also having concerns and questions. So we need more data and more information, collection of more information post-authorization in order to support the decisions of the treating physicians for our patients. And there is from Khaled saying that I think prioritization should depend on the presence of allo antibodies in which patients may not be able to reach the recommended pre-transfusion levels. Well, that's one of the reasons for supporting and providing. Yes, I think, yeah. Yes, John or V?
So as another point, we talked about the lack of availability of blood from blood transfusion centers, but of course, if an individual can't receive regular transfusions because they have alloantibodies, this might be an intervention that helps. Yeah,
I agree. I think this can be another important reason that that why the patient should get the luspatercept, especially when they have this alloantibody and has the some difficulty to find the matched blood to receive the adequate transfusion.
Mm-hmm. Just before we read the last comments, Riyad, you have a second point?
I want to make a comment regarding the bone pain, because I saw a comment about bone pain in the patient after the first. Oh, okay. I think Maria can also share her experience. Based on our experience, the bone pain will develop during the first or second or not beyond the third dose of the luspatercept. And after that, the patient, most of my patients, they can tolerate and they don't no longer feel any bone pain anymore. This is just something that I want to share, and most of this bone pain can be relieved by the use of NSAID, and some of my patients take only 1 or 2 pills and it's all gone. So I think this is the adverse event that reflect that the drug is working on you. and it doesn't really prohibiting or contraindicated for the further use of the luspatercept. This is from experience.
Thank you. I think patient story help and support very much, the how they feel and how it goes away, or how it. So we need to put out more and more patient story for our patient community. One last. What's the last one now? Sorry. Some patients take an assortment. Well, Helen, we have medics here, so I don't think they will support the herbs and supplements, but let me ask what you are asking. Some patients are taking an assortment of herbs and supplements to maintain deficiencies. Can this interact with taking the Reblozyl in any negative way? Herbs and other, we don't know, do we? Clinical trials or what?
Depends what the herbs are, I suppose. But I can't think of any immediate interaction.
We have legalized marijuana, so.
Personally, I've been on wheatgrass for 4 years, and that was way before I went on luspatercept, where wheatgrass, which contains chlorophyll, and if you see how chlorophyll is very similar to the red blood cell, it goes inside the red blood cell and makes it healthier. So prior to luspatercept, I was on wheatgrass for 4 years, and that has raised my hemoglobin as well. And I take both. Every morning, I take my wheatgrass right after breakfast. And it's good for many, it's an antioxidant. It's good for many, many things.
Thank you, Maria. Can we have Dr. Hafizur Rahman?
Yes, yes. Can you hear me?
Yes.
Yes, I am Dr. Hafiz from Dhaka, Bangladesh. Hi, everybody. You have already mentioned by different speakers that we have a lot of thalassemia patients in Bangladesh. Majority are with β-thalassaemia, with intermediate or very mild severities. How we can address this problem in Bangladesh, where β-thalassaemia measure is less than that of β-thalassaemia. And I am doing my job at ICDRB, an international research center, where a clinical trial unit also there. We are conducting several clinical trials on neurotransmitters, different drugs and vaccines. Thank you.
Well, Vip, I think, being in the intermediate in hemoglobin E, perhaps you'll be the first one to answer.
Yes. I think the data from the Beyond trial are very, very encouraging. The use of luspatercept in NTDT patients, especially in ETAL. So we got quite a number of the patients who respond so well to the luspatercept. And I think, we have even project that, the early use of luspatercept, especially in pediatric population, might be able to help reduce the need of blood transfusion later on in life in a lot of ETAL patients. So, but I think we still have a lot to learn and do the clinical study. So we are doing that. Yes.
Thank you.
So I just read the question, Andrula, regarding the measurement of the erythropoietin. So you want me to respond to that? You have to unmute.
Sorry, so that's exactly what I was going to read. That's one of the last questions. Do we need to measure erythropoietin before starting Reblozyl? I wonder if the level of erythropoietin could affect the response for Reblozyl, especially in TDD patients.
I think the answer is no, because I think the point of action of the Reblozyl is in the second half of erythroid differentiation in the erythropoiesis. So it's not EPO dependent. The EPO, the erythroid stage, that EPO-dependent will be at the early stage of erythropoiesis, but the Reblozyl will acting on the second stage of erythropoiesis, which is EPO-independent. So, and based on the BELIEVE trial, I don't think that we see any correlation between the clinical response and the level of the EPO, if I understand correct. But John may know better on the other erythropoietic markers such as the TDFM.
So thanks. I think the thing I would follow at the moment is soluble transferrin receptors, if you can, because there may be a long-term trend, and it may indicate if you're getting an increased risk of EMH if you give long-term treatment. So that's one thing I would follow.
Yeah.
Thank you. That's clear answer. Agreed on both. And last, Paul Telfer, you're raising your hand. Yes, please.
Yeah, thanks, Andrew. Just to come back to Dr. Hafizur Rahman's comments from Bangladesh. Thanks very much. And it's quite interesting. There have been some studies from Bangladesh on use of a drug called thalidomide that many of us know about in thalassemia and e-thalassemia patients, showing quite a dramatic increase in hemoglobin level and reduction in transfusion dependence from Bangladesh. And I think we've had 1 or 2 patients who have become transfusion independent with apparently a very large increase in fetal hemoglobin level while taking thalidomide in a kind of anecdotal outside of sort of clinical advice, if you like. But I think the point is that there are some potential other alternative ways of increasing fetal hemoglobin and improving erythropoiesis, which need to be explored in more detail. Thalidomide does have some potential side effects, and I think it's important that it's evaluated in a rigorous way. But there has been some early work in Bangladesh on that.
Mm-hmm. Thank you. Vip, you are nodding. You need to add something.
I agree with Paul. I think there's several publications, especially from India and from Bangladesh, about the use of thalidomide that I'm aware of, but it's not have not really been extensive analyzed in a more clinical, proper, randomized trial placebo control yet.
Okay, John, you
Yes,
need to
yes.
something else or no? Thank you very much, Paul. The last question, last but not least, is should we stop prescribing or taking luspatercept when a patient, when a patient shows symptoms or is infected by COVID-19?
My answer was yes.
Sorry.
You have to get survive from the COVID first, okay? And after that, you will come back and enjoy, the quality of life improved by luspatercept. And we don't know the drug interaction yet. You have to use the antiviral drug, you have to use steroid, molnupiravir, and whatever. We don't have data about the drug-drug interaction, so please stop and get survive first.
So let's be cautious. Yes, John? You agree? We can't hear you.
You have to unmute.
Yeah,
John.
no data on that really, but I mean, if the patient gets COVID, they may still be under the influence of luspatercept. There's not much you can do, but by the end of that time, you can probably carry on. So there's probably no interaction to worry about.
Okay. We need to stop here. I'm sure there are many questions coming up, and thank you very much, Professor Porter, Professor Reblozyl. Thank you for Professor Paul Telfer's interaction and other doctors that were here with us. Thank you to Professor Nika Cabellini. And we need, as a global patient community, to do much more. Authorization was just a step, but we need a lot of efforts to understand better the use of this drug, the collection of data, the discussion and the interaction with the governments, with the regulatory authorities, with the industry very much, which has been extremely helpful in collaborating all these years of the clinical trials. Now we need to show the same collaborative spirit for making the drug available and accessible to our patients. So we will have the minutes of this webinar. It's being videoed, as you know, as all our webinars. Answers and questions will be answered, and we are planning to develop the TIF patients hub of questions and answers for our patients, the education of our patients, and perhaps with your help, the experts' help, to develop some hubs for the treating physicians. We'll take upon Mrs. Chulis also recommendation on the studies in developing economies. And last but not least, to thank TIF, the office, Royad, and my collaborator here, Michael Angastignodes, for this session. Thank you all so much, and have a pleasant rest of the day. Thank you.